you know who our guests are. I'm delighted that you've come to hear them, and I suspect we'll all pick up some new information. Which one of you is first? And it looks like we have the Deputy ADM first.
Don't make that mistake. I have a very competent boss, and thank goodness for that. Apologies for the false advertising on the photo. I got a few emails saying, when was that taken? In 1982, Helen? So there we go. Somebody was exuberant in my office. I probably don't need to tell everybody in this room why we need to transform the system. And usually we spend some time, and so with deference to my colleagues who work at the Ministry of Finance, I'll do a little bit of this briefly. Pretty clear that the spending levels that we've had over the last decade and growth of 6% is not sustainable. And as we look out into the future, in 20 years, we think we would actually, if we spent the same way we do today, healthcare would consume about 70% of all government program spending. And when we start to look out 30 years with the demographics that we have and the aging of the population, it looks like we would actually have to spend another $24 billion in healthcare. So that's a 50% increase by 2030. So those are the things that keep my colleagues in the Frost Building up at night, and why transformation is important not only for the health sector, but also for the Government of Ontario. We also have some complex problems in the health sector, and many of you are probably working on those challenges. Alternative level of care rates, and return to the emergency department after a hospital admission. We've got I think patients telling us on a regular basis that their navigation through the healthcare system is less than smooth, and that there's a whole lot that we can do to actually improve the quality, the patient experience, access to care, and the overall value of the services that we offer. And that's really what transformation is all about. We've had some terrific work done by our colleagues at ISIS around, trying to segment the patient population and give us some places to start. And not a place to finish, but a place where we might actually be able to have the most impact to meet those 4 objectives I just spoke about. And so we've looked at, 5% of the population actually represents 66% of the healthcare spending, and 1% is about a third. And think about what the patient journey must be for a person who has, if you look at the 1%, most of them have 6 doctors or more, and in fact 25% of those patients have over 16 different physicians. That's a heck of a journey, and I think that's something that we can probably make a big difference in, and that's where transformation is taking a pretty square aim at. I think the great thing in comparison with other sectors in the broader public sector, and the thing that characterizes the healthcare sector, is its leadership and its willingness to transform. And I think about the numbers of tables that have been engaged around health system funding reform, the leadership of our LIN colleagues, and the leadership in all of the health sectors, and their willingness to step up and to have the conversation about working together differently. And certainly the take-up of HelpLinks has been, a phenomenal testimony to that. And I would say that understanding of the need for change and the willingness to work together is not shared in other sectors. And we had the benefit very much of many different reports and ad hoc groups of health sector leaders coming together to give us advice, and I think we actually took some of that. In this province, the e-health journey has not been perfect, but we have a connectivity that I think is starting to really be able to help us build care teams and to coordinate care within the circle of care, and I think that's now a huge asset for us. And we have an apparatus in Health Quality Ontario, and where I came from, and the program in evidence-based and cancer care Ontario, and other organizations to create evidence, and that certainly was not the case when I started in healthcare back in 1986. So again, a terrific source of support. The action plan is really what's guiding our work in terms of the overall objective, and the minister was here. She would talk about more eloquently than I can about Ontario as the healthiest place in North America to grow up and grow old, but 3 main buckets of work: system focused on wellness, faster access to family health care that serves as the hub of the system, and better integration and accountability. It's a pretty big agenda, lots of moving parts, so we try to parse it out into something that's maybe a little bit more concrete and a little bit more manageable. So many of you probably have been involved or impacted by funding reform, where we're starting to pay, I think, more fairly on the basis of the characteristics of the population. That's HBAM, a health-based allocation model, and then quality-based procedures as well, that's actually looking at a patient journey, what quality is, and paying on that basis. Most impactful this year for hospitals, but starting to reach out to community care access centers. And it's a pivotal part of transformation. I'm going to spend some time talking about health links, but clearly we have an agenda to actually integrate care. Again, health links focused on the most complex patients, but we have other initiatives where we're working on improvements in the delivery of those services. On delivery streams, sometimes my boss calls it channel management. We're looking at kind of who does what in the healthcare system. You've seen some recent announcements around birthing centers, and the minister not that long ago in her OHA speech talked about some of the other areas of focus for us. So dialysis, where I most recently worked, is on the list, so is colonoscopy. But looking at, are there opportunities for us to shift the locus of care to be more patient-centered, more cost-effective, and improve access. But we have already done things in long-term care, for example. We call them assess and restore beds, where we're actually looking at our long-term care capacity a little bit differently than we've done historically, and are there opportunities to use that for shorter stays so that people can actually go home again, and I think those are very promising. And then finally, wellness and prevention and streams of work. I think some of those are still in motion in terms of what action the government's going to take on the Healthy Kids panel, the further deepening of the work on Smoke-Free Ontario, and some important work that's emerging around the role of and the work that we can expect from our public health sector. So what does transformation mean for the system? And I think a lot of people have those kinds of questions as, what's the system going to look like at the end of the day? I think it's important to think about how we've framed transformation as co-design, and it really is very much working with the sector to try and build the system to achieve certain objectives. So I may not have a perfect picture for you, but I think we've got some ideas about what we want to aim toward. There's a stream of work around making the best use of our health human resources, creating systems that allow providers to spend more time with patients, integrating services, making sure that we have greater accountability. And I think there's a sea change in the accountability area when we actually want to somehow find a way to execute shared accountability for a patient population. We've got still a journey on higher quality, and lots of work happening in the quality improvement plans of health service providers, and ongoing searching for evidence about what makes the biggest difference, and then trying to be transparent in how we all make decisions together. So I thought I'd spend a little bit talking about the Transformation Secretariat, because we're actually the only one in Canada, and some people kind of wonder, what the heck are we doing? Because many of you who work in this sector still have important relationships with my ADM colleagues. And so really it's responsible for trying to energize and mobilize the sector, so I hope we're successful in that. We're trying to work within some provincially driven objectives, and certainly we've got very clear metrics for health links and as well as for transformation, but trying to allow for local driven solutions. And it's really a time to innovate and look for, I guess some people call it positive deviation. I don't know about that, but certainly looking for points of light in how we can actually make improvement. We want to support collaboration at all levels, whether it's between providers locally or between ministries in the world that I live in, making the most efficient resources and ultimately resulting in better system utilization. So I have shared accountability for transformation results with the other executives in the ministry. We spend a lot of time trying to align the system assets to achieve transformation, whether those are programs within the ministry or whether those are supports provided by our agencies, including the LHINs, Health Quality Ontario, and others, to make sure that they're best aligned to actually achieve transformation. We do have a set of metrics that we're tracking, and we're tracking progress on all the transformation projects across the ministry. We do have a list of risks. Change is not without risk, and there certainly are some in the amount, depth, nature of change that we're talking about. And we're trying to mitigate those as much as possible and be clear about what we can do and what we can't do. We're trying to improve communications with the sector so that you understand what it is we're trying to achieve and have an opportunity to, I guess, internalize that and find your place within the transformation agenda. So I'm going to spend a little bit of time on health links, and part of the reason why I asked Matt to join me today is that Matt is the co-chair of the Health Links Advisory Table, and I think again it's another example of how we are working very closely with the health sector leadership on an ongoing basis to make sure that we're on track and we're doing the kinds of things that are going to make the biggest difference. So health links I sometimes think of as the ground game for transformation. They are a new way of working and very much focused on clinical integration. So we have strong provincial programs. We have terrific LHINs doing work in their geography. And this is something very different that builds on the work of, again, some terrific scientists at ISIS around natural referral patterns and trying to animate, support, and uncover those important clinical relationships around patients. The focus, as you know, is on the most complex patients. We have a bunch of criteria for who can actually become a health link. But the bottom line is that we're looking to health links to develop coordinated care plans for the most complex patients, improve their quality of care, their patient journey, and make a difference. And when summed together, that will actually start to transform many of those clinical services that those complex patients actually access. I would say the take-up of this pretty basic idea has been remarkable. So I tell the story, which is true, that we, this one happens to be true, we went in late October to get permission to do this kind of work from the decision makers, including the Premier at the time, and said, how many can you get? And I said a dozen, and my boss, who's always ambitious, said in 4 weeks. And we had 19 by the beginning of December. We have 25 now, and we have a number of readiness assessments in progress. So I think it's a testimony to the fact that improving care for patients, at the clinical level is something that probably we all got into the business for. And that we've tapped into the intrinsic motivation and the stories, and you'll hear a little bit from Matt, that are emerging about providers actually getting to know each other better through this process, starting to develop care plans, starting the transformation journey very locally, I think is very heartening to us. And our commitment is to share those stories so that we can accelerate the spread of the innovative practices that are emerging from health links. We also have a diverse leadership model, so unlike what some may have liked us to do, which is to declare a sector as the leader of the healthcare system, we decided not to do that deliberately and on purpose. And in fact, you'll see here that we've got, from amongst the 25, we've got a pretty good diversity of leadership. Draw your attention to the fact that really more than half are led by primary care. And for those of us who worked in the system for a long time, getting traction and building out that relationship with primary care has been a challenge with over 10,000 individual practitioners, better organized today than ever before. And they're starting, when they start to look at the needs of these complex patients, to look at all kinds of different partners. So this is a discussion that goes beyond, hospitals, CCACs, and primary care. It, as you see here, includes the food bank, in some cases police services, community support services, housing providers. And you can imagine the kinds of discussions and relationships that are being developed now that will actually help the patients of greatest focus for us. So the journey for sure is to cover the province. And we're ramping up probably faster than I thought we would. Job one in the first year is to develop care plans and attach patients to primary care. We're hoping that we'll get some traction on some process measures early on, again, for those patients, and ultimately make really sizable improvements in patient experience and ultimately in the overall cost of the care for those high-use patients. I usually put this slide at the end just to remind myself that this is a big transformation, that we've got a lot to learn about change management. And so we borrowed from the NHS, their change management framework, and have had many good conversations with them and with the field. And as we sort of think about all the things we have to line up to pull this off successfully, it's a little bit daunting, but we've got, again, as I mentioned, lots of capabilities, improvement methodologies, for example, at Health Quality Ontario, system drivers nicely over in funding reform. We've got a measurement group, but I probably spend my time thinking about, engaging with the field and spreading innovation and making sure that we actually move those experiences. So we've got work in all these areas. I won't go through it all, leave time for questions, but I think this is a really good guidance for really managing change. And we have a website, finally, thanks to, I think, Leslie's prodding and our change management group. So this starts to describe the action plan. There's information on health links, on funding reform, and we've got some space for the health links to actually connect with each other. And we've started a chat room and other things. So I'm hoping that it will be an animated, lively discussion and that we learn a lot about transformation from the field. So with that, I'll pass it over to Matt.
Thanks very much. Thank you. Thanks very much. In terms of helping Anton determine why we got the packed crowd here, I would just point out this is probably my 5th or 6th time at Breakfast with the Chiefs, and I've never gotten a standing room only. So I think we all know who we're here to see. For the record as well, Anton did not invite me. Helen invited me. Anton invited Helen. Okay, so he knows, he's a businessman, he knows who's going to pack the house, so he invited Helen. Helen wanted some support, so she invited me. Comic relief, perhaps, I'm not sure what it is. All right, so a couple of things, and it is quite a pleasure to work with Helen, and I just need to work on the computer here. There we go. And I'm going to start with one of Helen's slides, Transforming the System. And it is a very comprehensive agenda. I think that I'm mostly involved on the HealthLink side, but I get to see some of these other elements playing out as I get to participate in some of the meetings. And I think it's very important. I want to start at that high picture of that transformation agenda. I'm going to drill in a little bit into hospitals. I would try not to bore you too much with hospitals. Well, the good news for those of you who have heard me speak before, you know that typically I used to talk about University Avenue and how that was basically the center of the universe. I've changed jobs, and I've come to the realization that I was wrong. The center of the universe is not University Avenue, which my friend Gary Switzer from Windsor has been telling me for quite some time. I have learned that the center of the universe is in fact north of Etobicoke. So I'm going to talk a little bit about that and then come back to our health links. So when inside our hospitals, we think about the system and how the system works. I just want to put up this spending slide. It's a couple of years old, but I don't think the percentages have changed all that much in terms of where our healthcare dollars are $44 billion being spent. Now, it's nice having it on that circle, but as we try to think about it, we want to try to think about a healthcare system. So we try to map it out across a continuum. And just to give you a sense of the continuum, so this is very, very high level, very conceptual. The idea is that on the left-hand side of your page are community-based resources. On the right-hand side of your page is acute care resources. And of course, hospital operations at about a third of the healthcare spend. I know that definitely we can spread it all out. We didn't get too fancy. The idea is that most of the healthcare spend would be on the right-hand side of that page. Okay, so about a third of your spend is in hospitals. And then you've got the community care and long-term care, and again, the concept that that's mostly on the left-hand side of the page and not community side. I just want to pause on this point to say, you know, a lot of the rhetoric comes about we've got to spend less on hospitals or on hospital-based care. When we think about sustainability, financial sustainability, we tend to spend time talking about the acute care side, and we need to invest more on the left-hand side and invest less on the right-hand side. And largely that is a true statement. Okay? But for any of you who have worked in doing change management, the idea that we're going to achieve 100% of our transformation against 33% of our spend, that creates an almost impossible scenario to actually improve the healthcare system, which is why I think, although it's a bit ambitious of Helen's agenda to look at it more of a system, I think you have to. Okay? Now, also notice that what's up on this page is only about 50% of our spend. As we think about where are we going to make our transformation, you've got to get the other 100% on there. You've got to get the drugs on there. You have to have OHIP on there. OHIP is the second biggest spend. Now, we've just put these across as sort of boxes. I don't know how the distribution would work, and actually that's one of the things I think we should understand is how much of that OHIP billing, how much of those drugs are occurring on the right-hand side of that chart versus the left-hand side of that chart. And then there's this great bucket called all other. We're not 100% sure of everything that's in all other, but it's a big all others. It's almost 20% of our spend. We need to understand what's in that all other and how much of that is on that right-hand side and how much of that might be an area where we could get more efficiency and invest back into the left-hand side of this page, okay? So this is something that we need to think about as we think about this whole transformation, and I'll come back to it throughout my talk. I think Helen's agenda does come to the idea that you've got to look at this holistically as a system. So I'm going to just drill in for a moment into hospital operations. Hopefully I won't bore you to tears too much, but just to give you a sense, there's no question that if we're going to make the kinds of changes that we're talking about, the quality changes, the system sustainability changes, 1/3 of the spend is in hospitals. We've got to figure out how to make them operate more efficiently and a little bit differently. So here's an example of one of the frameworks that we're working with up at Osler to try to understand better our spending and how can we make this shift of higher quality, lower cost. So we break it into this matrix. Let's see if this little guy's working for me. No, not quite. Okay, so pretty simple anyway. It's just a matrix across the top. We've got scheduled and unscheduled care. Down the left axis is outpatient and inpatient, right? So pretty basic. If you think about unscheduled outpatient care, that's your ED, right? Unscheduled inpatient care are people coming into your inpatient unit through the ED. Scheduled outpatient, your clinics, and scheduled inpatient, there are some procedures that we do on a scheduled basis that do result in an inpatient stay. So this is what, at Osler, the cost versus activity would look like. So at Osler, unfortunately, we see almost 200,000 ER visits in a year. That's in 2 sites. Last year, unfortunately, 124,000 ER visits just at the Brampton Civic, okay? So you can see 200,000 visits, about 8% of our cost. Our scheduled outpatient care, about 400,000 visits, 14% of our cost, okay? So more efficient, not dramatically more efficient than our emergency basis, but a more efficient quadrant for sure. Look at the one in the bottom left. 63% of our spend on 44,000 separations, right? That's your big box. That's where we're spending the bulk of our funds. 70% of our funds are being spent in unscheduled care. So as we think about this transformation that the government is asking us to do, and we think about what's better care, well, for sure, although even though the costing wouldn't be substantively different between unscheduled outpatient and scheduled outpatient, certainly the quality of life and the quality of what's going on with that patient is very different in that right-hand corner. And certainly when you think about both quality and cost, moving away from relying on inpatient care into scheduled care is where we want to go, scheduled outpatient care. Now, if I take this a little bit further and think about how do we make this shift to scheduled care. So These are some graphs. These are the same quadrants in the same order. And we just sort of mapped out, unabated, based on our current trajectory, what does our costing look like and what does our activity look like. And you can see, particularly at the top left, the unmitigated growth in RED. Okay? And we're already, at Brampton Civic, 124,000. At Etobicoke General, in an ER that was built for 35,000, this year will come close to 70,000. Okay? So we've got to get that curve under control. If you look at the scheduled side, the reason that dips is that's us saying that if the unscheduled continues unmitigated, we will actually have to turn off the tap on the scheduled side to accommodate, assuming, of course, constrained resource environment. In a constrained resource environment, the stuff that we can control, we have to actually bring down. Now, I just showed you on the chart before that doing this strategically, that's the side that we want to bring up. But we would actually have to bring that down to accommodate the unscheduled care. So what we're working through now, just on a modeling basis, is what would the shift have to look like to represent a healthier, more sustainable environment? And we started by looking at what do you do on this scheduled basis, and what kind of changes, therefore, would need to occur on the unscheduled side. So when we think about where we want to go inside the hospital, for sure we can affect what's going on from a scheduled care perspective. When we talk about scheduled outpatients, so just focusing on that top right-hand corner box, we also think about that in 4 different ways, because each of these has their own cost structure. So there's hospital-based outpatient care, which is the most common, very familiar, I'm sure, to everybody here, the concept of day surgery, other things where you're coming into the hospital for some kind of clinic visit or day procedure. We also, Osler has, and many, many hospitals have, community-based outpatient services. Many hospitals, certainly like Osler, would have mental health clinics, as for instance, out in the community. We've also been getting into the business of what we're calling community-affiliated outpatient care. So this is where the ministry is asking the hospital to provide some type of service, and then we subcontract that work out to a community provider who can provide that service at a better price point than we can, but quality and information is all exchanged with the hospital. And then the last one, of course, is virtual care. In our example there, telehome care, there's tons of examples around where we can go with virtual care. The theoretical change that we would like to see is a growth in these areas. Now, hospital-based outpatient care, we've got the arrow kind of going up. We weren't really sure what to do with that arrow, frankly. With the whole move towards specialty clinics and all sorts of stuff, we're just not sure. Are we talking about growth in outpatient hospital-based services? Are we going to try to shrink those? What kinds of services are going to be there? On an activity basis, they might, in fact, we may see that the overall activity on outpatient hospital-based services going down, but the acuity of those services going up. So we still have some things to think about around hospital-based outpatient care. Certainly on the other 3 buckets, we want to see growth, and certainly we want to see substantial growth on the virtual care concept. And I know many hospitals are working this through now. How do you move to that virtual care? Certainly the place where you can get the highest cost efficiency, and tying to this idea of keeping people out in the community, certainly moving forward with that. So that's where we're trying to get to when we think about how do we shift inside our hospital the changes that we need to do. But certainly, going back to my little diagram here, that's only going to get us so far. That's talking about how do we make that 33%, how do we make 1/3 of the healthcare system much more efficient and more focused on prevention and wellness and all those wonderful things. There's still the other 2/3 that have to be brought into bearing, and that's where we see, in particular, the Health Links initiative. So to spend a little bit of time on the Health Links, we need to see a different demand curve coming back into the acute care setting. You can say whatever you want. You can tell me that I have to be way more efficient, all that kind of stuff. When there's 124,000 people coming into that emergency room at the Brampton Civic and 70,000 coming into the Etobicoke General, Helen can tell me whatever she wants. Those people have to be served. As long as that goes unabated, we've got a real problem in making the kind of quantum shift that the system needs. So Helen's already described sort of the theoretical behind the Health Links. I wanted to spend just a moment on, we have 4 of our 5 Health Links are up and running, and just wanted to delve into one of the cases that we've done a case review on, to talk a little bit about what does it look like on the ground when we're doing some of this stuff. So the case that I wanted to examine was the case of Mr. K. This is not Mr. K, by the way. In fact, this guy's getting very popular because I saw this exact picture on a commercial on CNN last night. So whoever he is, he better have gotten good dollars for this because this picture's going everywhere. So Mr. K. So Mr. K, so an actual case has been reviewed by our Brampton HealthLink, I believe it was. And Mr. K is 74 years old. He's married. He speaks English. He lives with his son and grandchild. He's got a supportive environment. Mentally capable, mostly mobile. He does walk with a cane, but mostly mobile. Does not smoke, does not drink, but has a whole bunch of medical issues. Okay. And Mr. K, the reason that Mr. K came to our attention, and somewhere here is Kiki Ferrari, who's running one of our health links. I think this was one of her patients. The reason that Mr. K came to our attention is he's been in our ED 11 times in the last 18 months. He's had 4 inpatient admissions. So when we go back to that model, scheduled care and unscheduled care, and talk about where is it most cost effective, where's the highest quality of life, Mr. K, who has a lot of medical issues, but otherwise is a pretty reasonably healthy fellow, is showing up in our ER on a very regular basis and showing up on our inpatient units on a very regular basis. He also has more than 8 medications going on at any given time, okay? And he's more or less on his own trying to figure all that stuff out. So, what are we doing with Mr. K? Well, first off, we're very, very fortunate because we have a great leader in our primary care sector named Dr. Frank Martino, who spoke with us here about a month ago, and some of you may know Frank. So we get Dr. Martino involved, and Dr. Martino is this whole concept of health links and preventative care. It's a religion for Dr. Martino. And when Dr. Martino sees something like this, he gets very involved. We find who's the family doc associated to this guy. Oftentimes what we're finding is that the family doc was unaware that this poor fellow was showing up in our ER 11 times in the last 18 months and has been admitted 4 times, et cetera. So immediately we got to get that connection back with primary care. We're also very fortunate that we have a great CCAC, and our CCAC is very involved in the work that we're doing on the health links. And we get into discussions around reconciliation. We get into discussions around palliative care planning. I don't know if Dr. K or Mr. K would be in this case, but a bunch of the cases that we've been reviewing really are about patients who are palliative, but nobody's telling them that. And we're not managing them like that. And we're letting them come into our ER, and then our ER doc is discharging them and sending them back home. And then they come back again, and we're doing all these one-offs instead of perhaps having that sort of tough conversation, but holistic conversation about what's really happening with this person, and really should we be having them come into our ER and into our inpatient unit and being discharged and all that sort of stuff at what's really going on medically for this patient. The other thing that's very important in this one, which is a huge challenge for us moving forward, is a lot of discussion around better referral to our specialists. Okay, how do we get access for either for Mr. K or for his family health team to specialist care? And of course the answer is, well, we've got to set up better referrals, we've got to get our specialists sort of doing better. There's a whole bunch of logistical challenges to that, most of which we're able to overcome. One particular one that is a challenge that we're still grappling with, there's many that we're grappling with, but one in particular we're grappling with, is that if you do a referral to one of our specialists, the wait time is measured in weeks and months. If the doc just sends the patient to the ED, the wait time to specialist care is measured in hours. So right away, you've got an incentive to get somebody into the ER, whereas we're trying to get them out of the ER and get them into the scheduled care model. So we need to rethink at the hospital side, how are we providing access to specialist services? Certainly in a model like that, unless we can plan well in advance, you can get yourselves into some challenges. And for sure, on the plan well in advance, if we gave the Kiki Ferrari the mic, she would tell you that what we're really looking at when we talk about health links, we're dealing with the most acute. We got to move downstream a little bit, get to them earlier, so that that 1 month referral is an acceptable amount of time. So one more thing in particular on health links. In the Central West Lynn, we've got a great environment. We have 5 health links established that cover the entire Lynn. 4 are already up and running, as I've mentioned. We all report up into a steering committee that is chaired by our Central West CEO. Steering committee is also a really important thing for us. We have primary care there. We have public health there. We have the region of Peel, the health commissioner, sits on our steering committee. That's a huge advantage for us. Helen talked about the idea that the partnerships have to go beyond the traditional. and looking at other partners who need to be involved in our HealthLink work. So that's making for a great environment. The other thing that's a great environment for us is we have co-leads with all of our HealthLinks. So all of our HealthLinks have an institutional partner. In 2 cases, it would be Osler. And then we have a primary care co-lead, so that we try to get primary care and institution together. The institutional partner really is who's going to handle all the paperwork and the flow of money and accountability agreements and all that sort of stuff. It just makes it easier if you've got that in place. The other thing, just before I leave this slide, what am I doing in time? I'm speeding up. I got 2 slides. We're good. Helen's good. Helen, I can take all the time I want. Can I tell you, Helen? Yeah. The other thing I just wanted to comment on, and why a model like this has been at least very important where we are, is it allows us that concept at the bottom corner here, living lab. So each HealthLink, we can coordinate how we want to approach the various questions of how to solve these issues, because I don't think there is a single answer. We certainly don't know that single answer. So we can try different models and then report back in to say, what do we see is working, what do we see is not working? So I think a very important element to it. Just going to end with just a couple more slides. I'm going to just come back now to Helen and the transformation agenda. So we've spent a lot of time, both of us, on HealthLinks. I think these other elements of the transformation agenda all key into this concept of how do you affect 100% of the spend, not just the 33% of the spend that you're trying to pull out of. Very, very important. I think the funding reform, at Osler we have a list about this long of all the technical reasons why we think funding reform isn't working properly for us. I suspect every hospital out there and every CCAC could come back with a list this long of all the things that are wrong with the health funding reform. The bottom line is it's the right direction, is the things that we need to move forward on. Integration and execution. HealthLinks is not the only thing, thank goodness, that is going on to try to change the nature of demand coming back for acute care services. Delivery streams, the community clinics, I've already mentioned a little bit about scope of practice. All of those things are very important for us as we move forward. So we do see that sort of full picture as we move forward. Just to end on, before you think I'm completely Pollyanna or that I've been drinking earlier than normal, we do recognize there's a whole bunch of challenges, and I don't want to give you the impression that Osler has got this solved. We're modeling, we're trying to understand how we're going to move some of this stuff. Our HealthLinks, we've got a great framework, I think a great framework in place in the Central West Lynn, but it's early days. We're still understanding how do we move forward. In terms of the challenges, I could have done 3 pages long of challenges. These just happen to be the 4 that are in my face today. And if I was doing this talk next week, I probably would maybe even change these up a little bit. But the 4 that are really in our face today, number 1, labor agreements and timing of funding reform. Labor agreements are not coming in at 0. So that has a big impact on us. And our funding model does not acknowledge that labor agreements are not coming in at 0. So while we're trying to manage demand, we're also trying to deal with the fact that our labor costs are going up. So that's a challenge for sure. Latency of impact on demand versus fiscal realities. I don't know how to get around this one. It's going to take time. I think there's really great things that are happening. It's going to take time to see the impacts in terms of what's really happening for people in the healthcare system. But our funding realities, our fiscal realities are saying we need to deal with this now. You know, if this was private sector, what we used to do when I worked at Johnson & Johnson, if we were going to do a change of this magnitude, right? Think of a production line. You bring up the new production line first. You make sure it works. Then you turn off the old production line, right? So for a period of time, you actually have dual costs. You're quite inefficient for a period of time in that change. We can't afford to do that. We don't get that luxury. We're trying to change the expression I'm sure you've all heard was we're rewiring the 747 mid-flight, right? So this is what we've got to do when we think about the impact of demand on fiscal realities. Adding more independent providers to an already siloed system. So I'm totally bought in to the idea of specialized clinics. I'm totally bought into focus factories. I'm mostly bought into the idea that it can be done more cost effectively out in the community than it can be in hospitals. I'd like to see the math. I intuitively kind of get it, but I want to see the math. But my big issue is that these independent clinics, they're called IHFs, independent health facilities. I think that the I needs to change. The I needs to be integrated health facilities. These health facilities need to be under the auspices of the LHINs. The LHINs need to be able to do capacity planning. They need to bring everybody to the table when we do that capacity planning. And part of the agreement of establishing an IHF or a specialty clinic has to talk about how are you transparently reporting on quality how are you ensuring that information is being exchanged as to what's going on with your patients and your clinics with the rest of the system? So I get why we would do it, and I totally support it, but there are changes that need to be made in terms of how to make this so we don't have more independent facilities out there. We're already too fragmented. And then finally, this issue of health human resources planning. What worries me right now, and we are talking about it within the Central West Lynn, is when you're talking about that shift where you're trying to bring down spending on the right-hand side of the page and bring up spending on the left-hand side of the page, we need to be careful because we're headed down a path, I believe, we're headed down a path where you're going to be laying off people on one side to hire them on the other side. There's got to be a better way to do this. There's got to be a way that we can do this in a coordinated fashion. And one of those things that I think that I know I'm guilty of, and with due respect to everybody, I think we're all a little guilty of, when we talk about all this wonderful reform, remember that 70% of our cost is human resources. These are people. These are people who are going to go through a whole lot of change. What are we doing to minimize that impact as much as possible? Because right now I don't feel like we've got a good plan in place to say, if you're going to pull 100 or 200 people out of the William Osler Health System, and you're going to hire 70 back over at the CCACs or in the community agencies, how are we coordinating that to make that as little impact as possible? Pardon me, this is my lawyer phoning. So I'm going to stop there. I think that we're on, that was my lawyer saying stop, don't go any further. Or that was my outplacement counselor, I'm not sure who that was. So thanks very much, and I think we're going to take some questions.
So for those of you who are new to Breakfast with the Chief, this is where the rubber hits the road because you get to ask any question you want. So we have 15 minutes. I'll be with the mic here. Sarah, who's back there, will have a mic. So put up your hand and whoever we recognize first. Here we go.
Okay. We've got a few. We'll go right here. One.
You got one back? Shalom, you're not first. You're second.
Hi, it's Ron Noble. If you like the question, I'm from Trillium Health Partners. If you don't, I'm from William Osler. So yeah, it's actually kind of two related. In terms of HealthLink, in terms of the models that are out there, the 25, what are you seeing as what I'll call navigation models versus actual delivery of care models? Are you seeing a split? Are they leaning towards more navigation in terms of using existing resources in the community, or are you seeing new models of delivery?
I mean, I think it's pretty early days. I think, we're seeing, in some cases, CCACs putting into place care coordinators specifically for HealthLink's clients and devoting resources from their existing, resource base. The money that HealthLinks are getting is not to hire frontline workers. It's actually just to get the coordinated care plan process going and working. So for the most part, they're leveraging existing providers and relationships to actually build the care plan around the individual and bringing the team together. No. So I don't see a new kind of role being inserted into this from where I sit.
I would largely agree with that. I think that we're still in analytical stage on that question. And to Helen's point, right now what we're trying to do is figure out who should be doing all of this stuff and how do we leverage existing resources. We haven't spent any new resources yet on this. Whether we will need a new role or a different role or something like that, that's in our, for our HealthLinks is still a TBD. What's also been interesting is how many people are already acting as coordinators, which then begs the question, if we've got so many coordinators, how come the system's so uncoordinated? So we're trying to figure that out.
And the second piece is, when you spoke about integrated health facilities, what's the perspective on, public funds, whether they're publicly delivered or privately delivered or managed?
I'm going to defer to Helen on that question.
There's an awful lot of healthcare that is publicly funded and privately delivered, and I would point to, some of our home care providers as well as long-term care facilities and other sectors. So, we have a blended system today. I think that the expansion of specialized clinics is I guess the policy framework for that is still under development. There are a variety of different models under consideration. some terrific work done by McMaster to try and give us a sense of all the sense of possibilities. I know that this minister has indicated preference for not-for-profit.
Shalom, Government.
I'm not for profit. So here I am. The thing, I come with greetings from the PATH project.
Oh, great.
And we've started to work and things are starting to emerge. And one of the most interesting things that's happened is that there have been lots of interviews with people who are the top 5% and top 1% of users. And the thing that's extraordinary is that the things that would avert their coming to the acute care hospital for either emergency care or for admission are very often tiny things that are excluded by the system. So one woman said, I would never have to come here if somebody could only come in and help me vacuum once a day.
Right.
And the difficulty that we have in having those kinds of services delivered is a big problem. The boundaries that are set and how funding is set up and so on, and what the ground rules are, and a kind of deep culture of not spending outside your area, and the aversion, being tremendously risk averse and so on, are all of these things. So creating more fluidity in the system and allowing for a lot of those needs to be expressed really requires that we have a stronger patient voice, because a lot of the ways out of this have to do with ideas that come from the patients themselves.
Yeah.
So I need a little bit of support, says the caregiver, in order to avert this. I think that's one thing. The other thing is that a lot of the emergency visits have to be dealt with in a different way because of the needs of this particular population. The emergency room is focused not on the range of needs, it's focused on the particular problem of the body, and very often these people come with issues that could be resolved in a very different way. So we really have to rethink how emergency rooms, I think, operate in order to change both emergency and actually maybe change their boundaries. I don't know, but that's a very big issue, as you can see, and as Matt has expressed. I think that for that, one of the things that's still not said in the system, because it's also deep in our culture, is how much help patients and their families can give in that. Mm-hmm. And I think that that's a resource that's largely been untapped in looking at these problems. And I hope, and in the PATH project, we've actually managed to use that resource, and I hope that that resource begins to be used in the health links more and more.
Yeah, terrific. If I didn't comment on the excellent work of the Change Foundation, the people of Northumberland who have stepped up and sort of have given us kind of a beacon and an indication that this way of working has great promise. I didn't do them a good service in my talk, but it really is phenomenal, and we're trying to very much connect the emerging health links with the experience of the PATH project. And so as a practical matter, Genevieve is coming to talk to the health links on the 17th of June about exactly patient engagement and how that changes the conversation. And you know, my challenge back at the office will be to continue to try and be the silo buster and to try and create the flexibility for those good ideas as they emerge.
Yeah,
So.
I mean, I'll just make a couple of quick comments. So first, agree totally with Shalom's comments. Just maybe a few vignettes. One is that we try now as much as possible to present ourselves to our community as a whole, meaning not just Osler, but as for instance, we did a telephone town hall last week. It was Osler plus public health, plus the CCAC, plus Headwaters, so that people don't have to determine, you know, can I call and ask Osler this question, right? It's too hard. Just let them come and ask questions about the healthcare system, and we'll worry about that, sort of the other side of it. I think that the another little vignette is when we looked at the folks who were going into our ER, depending on who's looking at it, one of the studies that we did within our health link as they were reviewing the cases, where we had community-based resources around the table reviewing the case, they would often say things like, well, why didn't the ER doc refer this patient to wherever, right? And there's probably a million answers to why. One of them would be they didn't know, right? So that's one of the things we have to tackle is how do you get inside the ER, you know, and these are really, really, as you've heard, very, very busy people under a lot of stress. they're not going to be able to remember that there's all these other services out there that they should be referring to. So we've got to try to re-engineer how that process works a little bit. Third one that I comment on is that it's, if you went to Osler and said, and this is again where my lawyer may phone in a moment to tell me to stop talking, if you went to Osler and said, well, we're going to take 2% out of your budget and we're just going to hand that out somewhere in the community, I got a little bit of a problem with that. If through this work, so Kiki Ferrari, I keep picking on poor Kiki. Kiki is responsible for many things, including our ER. We saw that if we were able to send some money to a community agency for transportation or something like that, where we know it's targeted and it's going to try to move some of the shift away from reliance on our facility, and it's going to be cheaper, geez, we're all in. That's a great model. So we've got to think about how do we do some of that, and I don't think we necessarily have to rely on Helen and big policy changes to make some of that stuff happen, because I think that takes too long. Not Helen, of course.
No. But, and the thing is, when you look across the province, everybody's doing something innovative, somewhere, right? Somebody's taken a rule and actually kind of bent it a little bit and is doing something quite interesting. The challenge is to do this at scale.
That's right.
Right? And so, I take the risk pretty seriously, but I think it's, trying to do it not just for, in our case, Fred, Mr. K, but doing this as a repeatable process at scale so that we're transforming a system. We're not just making a difference for a patient or two.
Right.
And I think that's an ambition in which Ontario may be unique.
Will Falk from PwC, and a great session, guys. I wanted to pick up on exactly this last question, and you talked about transition at scale and some of the low rules pieces. Clearly, the ground war is going well. You've created and excited a lot of anticipation, and you've set a lot of expectations. In some ways, you've caused people to throw their hat over the wall, and now they're going to have to chase after it. So I think our chances of climbing the wall are much higher. To mix my metaphors, we need some air cover, right?
Yeah.
And Matt pointed out a great one on the labor transition issue. And I want to just get you in more trouble by asking you another labor question. We all have a mental mindset around the last time we did a major transformation, and that one may be wrong. We are in a very low unemployment situation in healthcare. Is there room for a provincial transition pool for the province to come in and take away the costs from the local hospitals to say, look, we are moving people, we're going to move people, and we'll backstop you? Matt, if you have to move 50 people that you know are going to show up somewhere else, we'll backstop those people for 6 to 18 months, and we'll make sure that those transition costs are covered.
So I think that we have a conversation to have about labor, how to meet our obligations to the people, who signed up to do this work, and try and change the system all at the same time. We certainly have put in the work plan of the ministry developing, a labor relations framework that would enable the work of Health Links and transformation to occur. And I think, it's something that we need to pay attention to. It's not, it's not one of those easy silo-busting ideas that can be dealt with quickly and, the environment that we live in. But I think that obviously we need to be, and we are paying some attention to that. We actually have already some transition funding within the ministry, because we know that it may not be quite as much overlap as the industrial example that Matt gave, but certainly understand, the principles and trying to make it work. And so we talked about designing the plane in the air, and that's probably exactly what we're doing on this one.
Yeah. I don't, on your specific example, Will, I don't know if that's the answer, but something like that, somewhere where we're getting that higher level, it's much better than right now. In our hospital, we're looking at what do we need to do with our labor force, and I know Kathy is doing the same thing with the CCAC. We've got a much simpler environment. There's only 3 or 4 big players, so we're going to get together to sort this out, but it needs to be sorted out on a bigger scale.
Andy.
So this is a question from Matt. I'm from Sunnybrook, but this week I'm one of Brian Golden's students. So
If you
question,
wanted to come work at Osler, yes.
the question relates to obviously a big piece about moving people out of the emergency squares into the scheduled squares, involves coordination with the myriad and really quite varied specialist doctors' offices in general. And you've spoken to some of the interprofessional teams and units that are going to be a crucial part of that. But how have you grappled with the challenge of looking at, and I'm sure this is the case in your environment, where there's all these highly varied settings for that the doctoring, especially specialist doctoring, happens. How do you frame and grapple with that, or how much of an issue is it?
Yeah, no, it's a significant one for sure, particularly out in our community. I would say when you get outside the academic centers, I think that this is a big issue. We've actually, thus far, we've largely just started with primary care. And can we establish a better working relationship with primary care in our region? The good news is, being that there's only us and Headwaters, that it's a captive audience with primary care. A little easier than in Toronto, where a GP in Toronto might be referring to Sunnybrook, they might be referring to UHN or Mount Sinai, all that sort of thing. So a little simpler environment. So we've started by trying to understand better where can we go with primary care, how do we get primary care more engaged. One of the things that, before the health links even started, one of the things that was quite rewarding was when we got the leadership being we offered anybody who wanted to come to a primary care meeting to come, and out of 350 doctors we got about 20, so that was not bad. What we asked them about what was, if there's one thing Osler could do for them, what would it be? And their response, which with unanimity, was they all believe they've got a handful of patients who are extraordinarily complex, they're not sure they're giving them the best management, and they'd like easier access to our specialists. So we've started to unpack that. We started with mental health, because that was by far the number one of the GPs. So now we're working with our psychiatrists and primary care to see, can we set up a model now to support this? I don't know that we can go every single discipline at a time, because going back to Helen's point, you got to get to scale at some point, but that's just sort of where we're starting to try to understand better how that relationship might work.
Well, it's after 8 o'clock. We don't like that at Breakfast with the Chiefs. So I want to thank Brian for enabling this phenomenal hall. This is the second time we've had an event here, and thank you for making that possible, Brian. The ACHE group goes to room 1020 on the lower level. Follow your leaders, and I'm sure that Brian, your group, knows where to go. Thank you for coming to Breakfast with the Chiefs.